Good morning. Welcome to another session under short course in clinical epidemiology, and belated Christmas wishes for all the attendees as well. So as a series of diagnostic test critical appraisal, we have now come to an extension of that. So today we'll be having a session on critical appraisal of a screening test. And it's my pleasure to invite Dr. Anna Paul, Associate Professor General Medicine, to take us through this critical appraisal with an example on a study of hepatitis C screening. I'll hand over to Dr. Anna.
Good morning, everyone. Hope you all had a nice Christmas. So today we'll be talking about critical appraisal of a screening study. So this is a case scenario. You had your ED posting, and you found 5 patients who tested positive for hepatitis C. Just incidentally, they had come with some other symptoms, and 5 patients ended up having hepatitis C positive. So you were wondering if you should introduce a routine hepatitis C screening to the emergency department. So now I'd like to start off by saying, what is a screening test and how is it different from a diagnostic test? So this is test, not a diagnostic study, a screening test versus a diagnostic test. So screening is for a healthy population, right? And you're looking at it from a population perspective, and it's often value driven, sometimes even political. So it's not just purely medical. So the key question is, does the test detect disease, but does screening improve outcome? So that's the key difference between a screening test and a diagnostic test. So the population, like I said, is asymptomatic people, whereas a diagnostic test is for symptomatic or screen positive patients. The purpose of a screening test is early detection, and your accuracy focuses on sensitivity, feasibility, and harm, whereas in a diagnostic test, you want high specificity and certainty. And screening is for a population level benefit, whereas diagnostic test is for an individual level test. Now you can screen, there are 3 different stages or types of screening. One where you're screening for an unrecognized but symptomatic disease. So for example, iron deficiency anemia, or like vision screening. So these patients already have the disease. They might not be symptomatic. So you screen for it, and then you can start treating that immediately. Now that can be you don't have to do an RCT, even just a longitudinal or a cross-sectional study can be done for symptomatic disease. When you screen for a pre-symptomatic disease, so that means the disease is present but maybe asymptomatic. So for example, like cancers, so like you're detecting at a very early stage, but it'll take some time for that disease to progress and for that outcome or mortality or bad outcomes happen much further down the line. So in that case, you would need to do a randomized control trial with much longer follow-up. The hardest thing is screening for risk factors. So which is like you're saying that dyslipidemia causes coronary artery disease. So you'd have to follow up for a much longer time. So what is that cutoff of cholesterol, HDL, LDL before that leads to disease? And modifying dyslipidemia, an outcome saying showed improvement of dyslipidemia itself does not equate to an outcome. So that's a much harder screening and much more difficult to prove. So it requires a large long-term longitudinal study. So now, what does the WHO expect before recommending or endorsing a screening test? So when you're suggesting or putting forward a suggestion, for it to be approved, there are certain criteria that it needs to meet. So this is the Wilson and Jugner screening criteria. It was actually proposed in 1968, and WHO still endorses it. So it has adapted it to current day situation and sometimes adopts it. And WHO actually provides for each condition. So WHO has a TB specific requirements. It has, I think, for cervical cancer. So each of these, based on the condition, based on the location, what the screening tool is required might vary, but this is sort of a broad principles of screening, which is used even to this day. And I'm going to be sort of focusing on this. So broadly, there are 10 questions. So it should be the condition should be an important health problem. There should be an accepted treatment. There should be facilities for diagnosis and treatment. There should be a recognizable latent phase. There should be a suitable test. Test should be acceptable to the population. Natural history of the condition should be well explained. There should be an agreed on policy on whom to treat, the cost of case finding, and case finding should be a continuous process. I will be coming into these in my subsequent slides. So like Dr. Vignesh mentioned, I'm going to use this study to extrapolate on these principles. So this was hepatitis C screening in the emergency department, the Detect Hep C randomized control trial. So section A is the basic study design valid for a randomized control trial. Did the study address a clearly formulated research question? So the patient or the population here were all adults presenting to the emergency department across 3 large hospitals in the US without a prior hepatitis C diagnosis. The intervention was universal. That means anyone who came in was offered if they were randomized to the intervention arm, anyone who came in was offered a hepatitis C screening test. The control is targeted. So that is actually standard of care at that time in the US, where you come in, you get a screening questionnaire like, do you have a tattoo? Have you had blood transfusion? And then you were offered a hepatitis C screening. And the outcomes here, they looked at hepatitis C case detection. And the secondary outcomes are linkage to care, treatment initiation, screening uptake. And the time follow-up was only 18 months. I'll come to these flaws a little bit later. And here, this is screening for a pre-symptomatic disease. And remember, we said it needs a randomized control trial. So that's what they have done, which is appropriate. So now, coming back to the Wilson's criteria, a screening tool requirements. I've sort of categorized them as the condition, the test, etc. So that for the condition itself, that means the disease, what are the requirements? The conditions sought should be an important health problem. So yes, hepatitis C is an important health problem. There should be a recognizable latent or early symptomatic stage. And the natural history of the condition, including development from latent to declared disease, should be adequately understood. So I'll explain in the next few slides why that's important. But specifically to our case here, hepatitis C, yes, hepatitis C has a long asymptomatic phase, and it's well established that chronic infection can lead to fibrosis, cirrhosis, and then liver failure. So hepatitis C is fulfilling all these requirements. So now, why do we need to know about the natural history? Is because of some biases that can happen in a screening test. So one of them is called the lead time bias. Okay, so what happens is so these 2 lines represent 2 different patients. Okay, so now this is a detectable preclinical phase. That means before symptoms, asymptomatic phase, where you can detect it with a screening test. So patient A gets the test done. So the screening is done and he dies at this point. Patient B doesn't get screened, gets diagnosis at this point and dies at them. So now if you look at this, the patient seemed to have survived longer as compared to patient B. But the time of death is the same. So for example, say CKD, patient is completely asymptomatic fine. At the age of 45, you screen for CKD, you pick up CKD. Age 55, he starts dialysis, 60, he dies. Another patient, you don't screen. At 55, he becomes sick, starts dialysis, dies at 60. If you look at its screen time, the patient survived from 45 till 60, but actually both patients died at 60. So this is called your lead time bias. It's not changing the outcome in any way, but you just pick them up earlier. So if you looked at survival time, it appears to be longer. Then you have something called length time bias. So here, what happens is when, so disease may have different ways of progressing. Say, take, for example, prostate cancer. 90% of prostate cancers are asymptomatic, not a very aggressive disease, might be indolent. Patients most often are not dying of prostate cancer, they die of something else. But there are few aggressive forms. So few patients might have a very bad disease. Or take a more common example, like hypertension. Most patients are like asymptomatic, long-standing hypertension, but few might have hypertensive emergency, they die. So the problem is when you screen, you end up picking up the slow disease or the stable disease. So say you go to a community and say screen everyone for hypertension or CKD. You'll pick up the stable patients who are not having bad disease. The ones who went dialysis, who got sick, are going to the hospital faster or dying faster. So in the screening, you pick up the more stable disease. So this is called a length time bias. So that also can happen. Then you can have something called overdiagnosis. So the patient, you might, because you screened, you might pick up something which probably made no difference to that patient's life. Again, prostate cancer is a classic example that, if you didn't find that patient have prostate cancer, he might have remained asymptomatic, gone on to have a perfectly normal life. But now you have diagnosed. So now you've diagnosed, you need to treat, you do additional tests, and you've just caused downstream difficulties for that patient, not really affected their outcome at all. So there's also something called stage migration bias, where, say, for example, you're detecting, you have a highly sensitive test, you pick up bone mets, so that now the patient's stage goes up. But normally that would not have been detected and would not have affected the patient's outcome at all. So this is why you need to know the disease process, the natural course of the disease, how it progresses. Only then it's appropriate to apply a screening tool. Now back to the CAST questionnaire. Was the assignment of participants to the interventions randomized? How was the randomization done? Was the allocation concealed? So yes, this was a web-based randomization and allocation. So a patient would get randomized and it was incorporated into the EHR, and an alert would come up or a prompt would come up during the triage and workflow. So I think the randomization allocation was done very well. Were all participants who entered the study accounted for at its conclusion? Were they lost to follow-ups? And were participants analyzed in the intention to treat or intention to screen arm? So here, they screened around 3 lakh patients. Around 1,47,000 were randomized, 75,000 in each arm. Now, if you look here, 65,000 were offered the test. Only 16,000 accepted the test. Only 9,000 completed the test. Similarly, in this arm. So at each stage, there's a big dropout. So now if you look at it in the traditional RCT way, there's a huge dropout, much more than 10%, right? So now is that a problem? Actually, in a screening study, this large dropout, especially in a pragmatic population-based trial, this is what you expect. There will be a large attrition. Okay, so, and screening is an offer of a test. So screening doesn't mean you have to do the test. A patient can decline it. So when it's an offer of a test, there's no guarantee of the test happening or of the screening happening. So you do expect large amounts of dropout to happen. So it has to be an intention to screen analysis and not a per protocol analysis. So what happens is it also preserves randomization. If you did a per protocol analysis, so say you looked at only 9,000 versus 4,000 who completed the test, you introduce something called volunteer bias. So who are the people who are likely to agree for a screening? Those are the people who are more health conscious, who know about the disease, who are likely to follow up. Whereas the person who refuses might be truly the person who has higher risk, has poorer access to healthcare. So there's definitely something called volunteer bias when you have a volunteer-based willingness to do the test. And also you need to capture population level effectiveness because screening is at a population level. So if you looked at only 9,000 and 4,000, you would miss out this huge, the 73,000 patient population, you would be missing out on that data. So now back to the Wilson's criteria, the screening tool, we describe what requirements are there for the condition. Then for the test itself. Now, there should be a suitable test or an examination, and the test should be acceptable to the population. So what do you mean by suitable test? So one, is it a cost-effective, easy-to-do test, right? And two, you need it to be good. So remember spin and snout. So you want a highly sensitive test to rule out the disease at a screening stage, right? So if you had a 50% sensitivity, that's not a test that you should be using. You want something that has a high sensitivity so you can rule out the disease. And the test should be acceptable. Say doing a 48-hour stool collection as a highly sensitive test to pick up some cancer. Sounds great, but who's willing to collect stool for 48 hours? Or even colonoscopy. If you said all patients come, I'll do a colonoscopy, you're picking up cancer, that still might not be acceptable to patients. So the test should be something that is good accuracies, feasible, and also acceptable for the population. So, but here in terms for anti-HCV antibodies is easily available, can be done easily. They even have a point of care test, and it has a sensitivity and specificity that is very good, both for the point of care and the antibody enzyme assay. So was the study methodologically sound? So this is an open label study. In fact, most screening tools would be difficult for it to be a blinded study, so it's acceptable. The study doesn't specifically mention about whether the assessors were blinded or not, but the outcome is, their primary outcome was HCV detection. So if RNA is there, it is disease, not disease. So it's a hard outcome, unlikely to have a bias. Were the study groups similar at the start of randomization? Yes, I thought most of the characteristics were similar, and there was no major difference between the study groups. So they've looked at age, gender, race, HCV risk factors, again, because the comparator arm looked at only, you don't have that data, language, that kind of. Acuity is how serious was the need for the ED visit. So apart from the experimental intervention, did each study group receive the same level of care? They don't explicitly mention it, but I assume so because it doesn't change any, it's just a one-time test that they're doing. So what are the results? So were the effect of the intervention reported comprehensively? Was a power calculation done? Yes, they did. Their hypothesis was that a 25% increase detection in HCV would happen. Now they've done like a simulation test because you saw how many people were offered the test, how many were willing to do it, how many actually did the test. All of this can vary, right? So they had to assume this. So they have done multiple simulations and arrived at this number. And they have given it an 80% power with two-sided alpha. And they've also accounted for site level clustering as well. So they've done a good sample size calculation. And there was no differential dropouts. So now coming to the outcome part. So in a screening study, I mean, any study also you want to look at the outcome that is most important as a clinician or from a patient perspective. And the idea of a screening test is not to detect the disease, is to actually improve outcome downstream. So say I detect breast cancer, is that reducing breast cancer related mortality? That is what is most important. And like we already discussed, survival time is not a good outcome because there can be multiple biases. But disease-specific mortality or all-cause mortality requires a much larger sample size and much longer follow-up. So that is often difficult to do. So then you have something which is called intermediate outcomes. Okay, so this is what most studies often use. So an example of an acceptable intermediate outcome is detection of the disease when effective treatment exists. So for example, in hepatitis C, there is a known, like you can cure hepatitis C. So by detecting the disease, there is clearly a downstream benefit that you can document, in which case detection is a reasonable outcome, or time to, or did they follow up, or how many percent completed treatment, or how many percent started treatment. Those are all reasonable outcomes in the context of hepatitis C, even in TB, because there is TB treatment. And we can look at how many started ATT or how many completed ATT. That would still be a good outcome. Whereas in prostate cancer, saying how many people were referred to an oncologist or how many people were referred to a surgeon would not be a good outcome, because if you didn't need, you might not have needed that surgery or treatment at all. It might not have affected their outcome. So it has to be in the context of the disease. Okay. So now back to the Wilson's criteria. So what are the other requirements that the screening tool needs? So there should be an accepted treatment for patients with recognized disease. Okay. So say, for example, Huntington's chorea or Alzheimer's. There are screening tests, but at the end of screening, can you treat? Is there any treatment that is there? No. So you shouldn't screen for a disease if you don't have any actual treatment for them. You might be doing more harm. You're adding anxiety, stress, they're worried about it. There should be facilities for diagnosis and treatment. So, for example, you screen for TB, but you don't have a lab to send sputum cultures. You don't have line probe. You don't have a DOTS program. So, after you've done this X-ray or sputum, you don't have anything to do next. Or say hepatitis C. What if the treatment was not available in India? It's only available in America. You can't be like, you have hepatitis C, now go to America and get treatment. It's not an option. So you can only screen when you have the facilities to confirm your diagnosis and offer treatment. And there should be an agreed policy on whom to treat. Okay. So for example, say we start a TB screening program here. So now someone has X-ray positive, but no symptoms at all. Now, are you going to treat this person as asymptomatic or as an infective patient? Are you going to give prophylaxis? Are you going to start giving treatment? IGRA positive but no other symptoms? You might give X-ray. So based on your screening, what are you going to do? You need to decide beforehand what you plan to do with that patient based on these test results. So coming to our trial outcomes. So they looked at primary outcome was new HCV diagnosis. These are the outcomes that I'm interested in. So appointment for HCV treatment, direct acting antivirals initiation, direct acting antivirals completion, sustained virological response at 12 weeks. And they also looked at all-cause mortality. But again, the follow-up was only for 18 months. So you're not expecting that to be great. So now while you look at the primary and initial outcomes, so how many tests were offered, tests accepted, all of them had good p-values, there was a difference. But in outcomes that you are actually interested in, if you notice, all the p-values, they were not statistically significant. So this is just, since we had a survival analysis workshop, I've just put the time. So because they looked at time to treatment initiation, time to treatment completion, time to sustain virological response. Again, as you can see, based on the log rank tests, none of this was statistically significant. Was there precision? Was there confidence intervals? Yes, for every single outcome, they had mentioned the confidence intervals. Do the benefits of the experimental intervention outweigh the harms and cost? So what are the harms that you can have with a screening study? So we already talked about overdiagnosis. What happens if you get a false positive result? So like the other day, Dr. Tambu had explained about you can have a highly sensitive and specific test, but if you run it on a population which has the pretest probability is very, very low, you will get some false positives. So there can be a lot of harm with the false positives. So there might be a lot of downstream tests that you do to confirm it. It can cause a lot of anxiety, a lot of unnecessary follow-ups. So say the truly positive patient, now say someone comes to you for blood pressure check. You're like, okay, I'll do a chest x-ray. Oh, looks like TB. Now there's no sputum. So he has to go for pulmonary appointment. So you have now caused this patient a lot of tests and anxiety and money because you have decided to do this screening test. And again, so staff time, someone has to do the test. It's a hospital bed. It's a procedure time. All of these things are downstream costs of this test that you're doing. It can be counted as harm. You can also have false negative results. So say your test is like negative. You're like, okay, I don't have it. Let me go donate blood. And you are hepatitis C positive. So the harm from a false negative, you're like, okay, I don't have cancer, but actually you do. And then, 5 months later, you've got stage 4 disease. So there are a lot of harms from false positives and false negatives. Then you have to look at the economic consideration. Okay, so the cost of case finding should be economically balanced in relation to possible expenditure on medical care as a whole. So this study, they have not done a formal costing analysis or cost-effective analysis. So we will do it here. So let's say cost of a screening program for 1 month. So say we have around 200 patients coming to the ED per day. So 1 month, you have around 6,000 patients. Based on this study, I have assumed, say 30% completed the testing. And so they had assumed 1% prevalence. From whatever I could find in literature, Indian prevalence is also around 0.5 to 1%. But assuming that ED, you have like higher risk patients, I've given a liberal 2% prevalence. And this is from WHO data. So, as we know, like around 20 to 30% of can have complete resolution. It's around 70 to 80%, then go on to have chronic disease. So you may be antibody positive, but RNA negative. So say antibody positive, 70% of them are likely to be RNA positive. And this is the cost assumption. I didn't have my workstations. This is just some arbitrary costs. So anti-HCV testing, say 2,500. RNA PCR is 4,500. And the 12-week course is 20,000. So if you assume these things and you calculate, so 6,000 patients came, 30% agreed for testing. That itself costs around 45 lakhs. 2% of the 1,800 are positive. So then you have to do that And so you test antibody in those many patients. Then you have RNA positivity, say 70%. So 25 have confirmed disease. That's another 5 lakhs for treatment. So your total cost is around 51 lakh rupees per month you would spend to have this screening of all patients coming through the ED. And because you're getting around 25 cases, you would save, or per case, you're spending around 2.6 lakh per case of hepatitis C detected and treated. Assuming patient then develops a CLD and has decompensated DLD, and they might have 2 to 3 admissions. So it's around maybe 50 to 75 lakhs. So we have to decide whether, because they have not done a formal analysis, we have to decide whether we think this is worth the cost or not. The other thing is the last requirement from the criteria is case finding should be a continuing process and not a once for all project. Of course, this is, at the end of it, whether you're implementing it is something that is important. Will the results help locally? Can the results be applied to your local population? I personally feel the number willing for the test in India might be higher, but might be lower, might be high. I don't know, but I just feel that more people are likely to agree for a test here. Again, I already mentioned before, the prevalence in India is sort of similar and maybe even slightly less than the US general population. The outcome, yes, we are also interested in whether the patient has detection and time to treatment. Although, again, only 18-month follow-up, so they didn't really give mortality outcome. I mean, they mentioned mortality, but you wouldn't expect a significant mortality difference. So would the experimental intervention provide greater value to the people in your care than any of the existing interventions? So here we come back to our case scenario. So how many of you want to start implementing hepatitis C screening? Show of hands. So clearly they have proved that you're detecting more, right? You're detecting more patients. So, but is it worth the cost is the question here. So, I previously calculated assuming 100 patients, 200 patients per day to the ED. But if you calculate it based on number needed to screen, you need around 82 patients need to be screened to detect one HCV. And therefore, the cost is around 2.3 lakhs for one HCV case. Will you do it? So I just want to point out that if you increase the prevalence, so say I increase the prevalence to 3% or 5%, if you calculate the whole thing, the cost per person actually comes down. The overall cost is more, but per case, the cost actually comes down when you increase the prevalence. So then would you want to change? Is there another setting where you might want to consider this? So I thought that maybe all patients coming to gastro or hepat OPD. So then their pretest probability or the thing might be more. So even if it goes up from 3 to 5% or 6%, that number comes down to, I think, around 1. Even 3.5% is, I think, 1.6 lakh as opposed to 2. So that would come down. In that case, would you be willing to change that? So the limitations of the study, they didn't have a long-term follow-up, so they didn't have mortality data. They did not do a formal cost-effectiveness analysis. Actually, one thing I felt was, so between testing, so accepted for test and testing, there was a big dropout, which I thought was a bit too high in the sense, so say for the test is an MRI. So you've come in and I said, are you willing to do this MRI? You said yes. But then by the time I arrange for the MRI, get you there, it's possible that you leave or didn't agree. But here it's just a single blood test, sometimes even a point of care test. So in which case it's a bit surprising that so many patients dropped out, but possible. These are my references. Actually, I used one of Tambu sir's previous presentation on a screening tool as well. I'd like to thank Tambu sir and Dr. Vignesh.